Hi there, everyone. Today we're going to talk about Chapter 15, Autoimmune Diseases, or Autoimmunity, and that's from your Clinical Immunology and Serology textbook. So we are going to talk about another series of diseases related to the immune system. We saw previously, we talked about hypersensitivity, and this discussion today about autoimmunity is really, again, looking at another dysfunction of the immune system. In this case, we're going to be looking at how the host's own immune system can turn against itself and attack healthy cells. Autoimmune diseases, we're going to see, can be organ-specific or it can be systemic. So the range and effect of the autoimmune diseases that we're going to discuss quite different. What do we know about autoimmunity, though? I think that it's well established that we understand kind of the actions of the immune system towards self, but the causation, the exact causation, is still pretty much unknown. We're developing and understanding more about it all the time, but we still don't know a lot. What do we know, though? We know there's a really significant genetic component to autoimmunity that we're going to discuss. Autoimmune diseases tend to run in families, and particularly women. Women are more likely to develop autoimmune diseases than men. And even more specifically, women of African American descent, Hispanic American descent, Native American descent, all far more likely to develop autoimmune diseases. We're also going to see today a very large environmental component that is associated with autoimmunity. And the study of the correlation between environment and genetics, it's called epigenetics. It's a really big topic in research right now in trying to understand that relationship between how genetics and the environment are intertwined and how they affect each other. And does something exposure in the environment make you more likely or less likely to have a genetic change, a genetic shift that results in something, for example, like an autoimmune disease? There are, depending on where you look, more than 80 or 100 different kinds of autoimmune diseases, and we're not going to talk about all those today, but I will try. I found a really great little resource last year. I'm going to see if I can find it. I should, and throw it up on the portal. It had a nice little synopsis of probably 25 of different autoimmune diseases. We're still not going to talk about that many. Today we're going to really review just a handful that have a strong laboratory component, and it's going to be a chance for us to illustrate the diseases of autoimmunity. But let's start and get going. This is just the chapter overview, so you can certainly review that at your leisure. We're going to start with autoimmune diseases. Autoimmune diseases, or disease, is an illness that occurs, as you know, from prior discussions, that the body's tissues are attacked by its own immune system. And obviously, we're going to have both arms of the immune system, both the humoral and the cell-mediated immune responses are directed against self-antigens. The humoral system obviously involves autoantibody, antibody towards self, and the cell-mediated immune system is has reactive lymphocytes, reactive T cells that are against autoantigens. So we call them autoreactive T cells. And so what happens in cell-mediated is that those autoreactive T cells have escaped that system for destroying cells that will identify self. And we're going to see in a few minutes, it's going to look very familiar to you, that it happens during the B and T cell maturation. We're going to focus mostly on the T cells today. It's a little more specific in T cells during T cell maturation. So we're going to see that and how T cells that escape that scanning and that testing whether they identify self as foreign, and whether they can ignore self. Um, that's going to be the basis of our autoimmune diseases today for both B and T cells. As I said just a minute ago, autoimmune diseases can cause, specific tissue and organ damage. It can be systemic, so it can be throughout the entire body, or it can be something very organ specific. If you recall, again, from earlier lectures, we talked an awful lot about the host's ability to detect self from non-self. We're going to look at the mechanisms of the host in detecting self. But in those cases where the detection method fails, the host loses its ability. It's called a loss of self-tolerance. If you remember that, self-tolerance referred to the ability of the immune system to accept self-antigens and to not initiate an immune response. Loss of self-tolerance results in autoimmune disease or an autoimmune response. This is just a really nice picture of a T cell that I liked. Sorry. And again, remember, self-tolerance is simply the host's ability to remain unresponsive to self-antigens. So because self-tolerance is that ability to remain unresponsive to self-antigens, we have to develop that. And we do that by something we're calling educating the cells. We educate B and T cells. And there's a couple of different processes to educate our immune cells to distinguish between self and non-self. And that's of paramount importance in autoimmunity. So how does the host establish self from non-self in normal circumstances? The host normally develops this tolerance through a series of events that are going to identify B and T cells, that are going to help B and T cells to identify which ones are going to react with self-antigens. And if we have identified a cell that will react with self-antigen, we know that the host will do a number of things to it, either kill it by apoptosis or a number of other reactions we're going to talk about in just a second. We're going to look at this as an overview first. So this is the T cell line, and there's an analogous process for B cells. So there's within this, for both B and T cells, there's a process called central tolerance, and peripheral tolerance. Central tolerance occurs at the site of cell maturation. So for T cells, we obviously know that's in the thymus primarily. And for B cells, it's where? Primarily in the bone marrow, right? So we're going to look at these two processes of central and peripheral tolerance. And the first one we're going to look at is central tolerance. It's going to be important to remember that central tolerance is not perfect. It's not perfectly effective. And so there's a backup plan. And the backup plan that we're going to see is once the cell gets out of its area of maturation, once it gets past that, if it does, and gets out into the periphery, then there's a second checkpoint to see if we can identify those cells that should not be cruising the host, because they'll identify self antigens. So as I said, there's an analogous process in both, and we're going to look at both of these. So if you look along closely at figure 15-1 in your textbook, on page 235, we're going to follow along with this slide. You'll be able to see this in action. Again, we're going to first look at self-tolerance. And as I said, it occurs in either the thymus or the bone marrow. We're going to look back at T cells first. And so we do have to take a step back and look at T cell differentiation. So does this look familiar to you? It should. It's from our discussion in adaptive immunity. I think it was chapter 4. We have this virtually this exact same slide with a couple of modifications to it, very few. So this is the process of central tolerance in T cells, essentially. So remember, it happens at the site of T cell maturation, which is in the thymus. in this, we can see that there were 2 points of challenging the cells to see if they're going to be capable of identifying or differentiating between self and non-self. And there were two places for this. The first place, and we see more of a discussion about it now when we're talking about central tolerance, but there's one stage at the double positive stage where cells are assessed for self-tolerance, and the bulk of the assessment happens in the negative selection phase, which is what we talked about when we were in the chapter 4 region. So if we are looking at this, if we're looking at this point of we went through the double negative stage when obviously they were neither CD4 nor CD8, and we got to the double positive stage. And if you remember, we have both CD4 and CD8 antigens on our double positive thymocytes. What was important in this stage, if you can think back to it, it was that quirky stage where the cells were tested to see that if their little T cell receptors are going to bind to self-antigens. And if they bound to self-antigens too strongly or too weakly, those cells didn't pass through to further maturation. So if they were, again, they couldn't bind too strongly. Double positive cells can't bind too strongly to self-antigens. They can't bind too weakly. If they pass that assessment, they move on through the process of positive selection into becoming single positive, where they become either CD4 or CD8 exclusively, and then they move on to the negative selection phase. At that point, we have individual CD4 and CD8 positive cells. They're not dually CD4 and CD8, but they are individually CD4 cells or CD8 cells. And again, these cells are now going to be challenged by self-antigen. This is going to occur in the medulla of the thymus. If these CD4 or CD8 thymocytes react with self, if they're autoreactive, here we go, if they're autoreactive, what's going to happen to the cells? There's going to be 2 things that can happen. Obviously, they can be programmed to die by apoptosis, which we all know that when cells are not appropriate in the immune response, they're targeted to die by the process called apoptosis. So they get deleted by apoptosis, or there's an alternative. Some of those CD4 positive cells, if they get by, and if some of the CD4 positive cells have a reaction with self, so they don't have self-tolerance, the immune system can trigger them to differentiate into a specific kind of a T regulatory cell that's going to actually, and ironically, inhibit immune responses against self-antigens. So that's the process here. Negative selection, right in here. See, there's this, this is a CD8, and this one's a CD4 cell. CD4, CD8, they get challenged by autoantigens. If they self-react, they either are killed by apoptosis. You can see here's they're killed, X'd out, or CD4 cells can also be differentiated into these specialty T regulatory cells that respond to self-antigen to inhibit autoimmunity. If the cells pass through this and they're during the double negative stage, if you remember, if the cells are not self-reactive, if they don't react with self-antigen, those are the ones that leave the thymus in a happy way, and they go off to the periphery, the secondary lymphoid tissues, including the spleen and the lymph nodes. They leave the thymus as an immature T cell and go out into the periphery. Let's see what happens then, because sometimes this process fails. And even if the cells may be challenged by self-antigen, they escape this path. They escape both of these challenges, and they go out into the periphery to the secondary lymph tissues. They escape, and we certainly don't want self-reactive T cells floating around. So, if you remember, I said there was a backup mechanism out in the periphery. So we just went through this. There's the apoptosis, and there's the differentiation of those CD4 cells that go out into the periphery, into the secondary lymphoid tissues. But remember, these were self-reacting lymphocytes. Now they have a process where they're not going to react with the self-antigen, but are going to instead inhibit it. So let's see what happens to those cells that have escaped the central tolerance, that have migrated to the secondary lymphoid tissues. What happens there? So this is our backup plan. The first thing that happens to self-reactive T lymphocytes that have made it through central tolerance, they got out to the spleen. The first thing is obviously apoptosis. Again, challenged by self-antigen, they're recognized to respond, and they are deleted by apoptosis. They're subject to cell death. That's easy. The other thing that can happen to these T cells that are self-reactive is that they can be inhibited. Their actions to react with I just lost my train of thought. I'm sorry. The cells that escape CD4, which are T helper, CD8, which are cytotoxic T, those ones that are responsive to self-antigen that escape can be regulated by those special T regulatory cells that were developed up here and differentiated up here. And these will actually inhibit the action of these cells. These self-reacting cells will inhibit the self-reacting function of those T cells. So it doesn't kill the cells, but it actually inhibits them so that the cells will not respond to self-antigen. How does it do it? They actually, this T regulatory cell, let's see, it inhibits kind of a signaling from antigen presenting cells, so that when they encounter antigen presenting cells, this cell, the T regulatory cell, inhibits the action of antigen presenting cells to trigger these cells to respond. So it's kind of these are an inhibitory function. I hope that makes sense. So it's this T regulatory cell inhibits a signal that would normally come from antigen presenting cells to T helper and cytotoxic T cells to activate them to react with self-antigen. So to summarize, in the peripheral tolerance, those T cells were regulated. The ones that were regulated in negative selection get out into the periphery, die off by apoptosis. They're inhibited by T regulatory cells. Specifically, if we think about, you should probably know this, that the way that it works is that there are receptors. There are T cell receptors. We know that T cell receptors on T cells, on both the T helper cell and the cytotoxic T cells, and there's inhibitory molecules that will inhibit that reaction. And the molecule that will inhibit the receptor is called CTLA4. It binds off to the T cell receptor and makes it so that those T cells can't be activated in the presence of self-antigens. So That's it. So I guess the last thing I should say is that process where I said that that lack of co-stimulation by antigen-presenting cells is called anergy, A-N-E-R-G-Y, or maybe called anergic. A cell may be said to be anergic or anergic. And what it means is that a cell has been rendered non-functional. Non-functional. So non-functionality of T cells, one of the reasons is due to lack of co-stimulation by antigen-presenting cells. If you say to yourself, okay, well, we went through central, peripheral, we went through central and peripheral tolerance of T cells, how do we end up with autoimmunity? Well, in some individuals, central or peripheral tolerance may still fail. That screening may still fail, and cells can escape. And so these reflect, if you can see it in really small writing, this says escape of self-reactive cells. So those T cells in the thymus, and later the B cells when we talk about them, escape central tolerance. They are tested again during peripheral tolerance. They escape again and they go out into the host system and are allowed to respond to self antigens. So when that happens, autoimmune diseases are what happens, obviously. Let's look at the process that we see in B cells. So we're going to look at the B cell part now. Hopefully you've got this so far. I think B cell, this is a little bit easier. What happens to B cells? B cells, as we know, develop in the bone marrow. And if the B cell in the bone marrow has receptors that strongly bind to self-antigen, or they have a high affinity for self-antigens, they get deleted by apoptosis in the bone marrow. They're just automatically, they're deleted and off you go. The other thing that can happen is something called receptor editing. What is receptor editing? What happens is those B cells that have immunoglobulin, cell-bound immunoglobulin, or membrane-bound immunoglobulin, B cells can change the receptors. They can signal a change to the receptors on those immunoglobulins. So they're no longer antigen specific. They're going to be sort of generic immunoglobulin attached to the cell membrane. It's no longer going to be specific for the self-antigen that it was challenged by. So when that happens, that process of receptor editing is said to downregulate the expression of the receptor. So it becomes unresponsive. So that downregulation really is just talking about changing the configuration of the antigen receptor, the FAB region of the antibody that's bound to the B cell, changes the FAB region, makes it no longer antigenic, or no longer responsive to self-antigens, I should say. So that's receptor editing. And of course, we can also always have some anergy, which is just making it non-responsive. So those are really these are the two, but it also can cause apoptosis here as well. So it makes it non-responsive to self-antigen. And it's just by downgrading the expression of those self-antigens, makes them not respond to self-antigen. So those are kind of changes that happen within the immune system. So we change this, or we remove we change the B cell formation into we're not going to be responding to self-antigen. Crazy, right? But like T cells, B cells can sometimes escape through central tolerance. They mature out of the bone marrow, move out into the secondary lymphoid organs, the lymph nodes and spleen, and going to be tested again. They're going to be tested again for self-tolerance. Those same self-reactive B cells that escaped central tolerance can again be deleted by apoptosis. or it can be rendered anergic or non-functional. And the way that it happens in the periphery is that a couple of things. They can be rendered non-responsive by being, repeatedly stimulated by self-antigens. So repeated stimulation of the B cell will result in changes that make them no longer responsive to self-antigen. I don't know, I joke, it kind of wears them down. Like, okay, yeah, not going to do anything anymore. And the last thing that can happen is they too can receive some, to make them anergic, they can receive some inhibitory signals through receptors like CD22 that will render them incapable of delivering a response against self-antigen. So again, in some individuals, B cells escape central tolerance, they escape peripheral tolerance, and they get out into they get released into circulation, and they result in autoimmune disease. The patient is more subject to autoimmune disease. Does this make sense? The processes of central and peripheral tolerance? I hope it does. Take a look back at Chapter 4, Adaptive Immunity, and I believe it was might have been also Chapter 4 for B cells. I think it was probably in both. It was in both. We did it in 2 lectures, I think. Okay. So we figured out the mechanism at this point. How do we get B and T cells that are supposed to be rendered inactive or destroyed if they respond to self-antigen? We figured out now how they escape that process and are allowed to react with self-antigens. But what does that mean to the development of autoimmunity? Well, we talked about, for a long time now, we've talked about the importance of genetics in the immune system. We started talking about it with MHCs, and that's a really a genetically controlled process of human leukocyte antigens, and how important genetics was to antigen processing and being able to recognize antigens, for example. Genetics and environmental factors are going to play a huge role in developing autoimmunity. So let's look at them. We're going to look at both environmental and endogenous triggers. What do we know? We know that the inheritance of certain genes can make some individuals more susceptible. I think I put a little cart before the horse here in my discussion. We just talked about the fact that women have a higher likelihood. Some are genetic, some of that is genetic, but some of it is also kind of endogenous triggers. One of which is female hormones. Hormones of women make them more susceptible to developing autoimmune diseases. And so if we know someone is genetically susceptible and then they have some of these triggers, they're gonna develop to the point of autoimmune disease. So what are some of the triggers that we look for? As I said, female hormones is one. Hormones influence autoimmunity clearly. Women are about 3 times more likely than men to acquire an autoimmune disease. Clearly it's an issue. Tissue injury can lead to disease as well here. And what happens there, and I wish I had an ability to write it in, but I don't. Do I put it on the next slide? No. So you're going to have to remember to write this. When there's tissue injury, the tissue is destroyed and it releases self-antigens that are kind of hidden away from the immune system. And those antigens that are hidden away within the tissue are called cryptic antigens. It's in your book, CRYPTIC, cryptic, like cryptic antigens. So those are antigens that were hidden in the tissue while the host was developing its sense of self, the early B and T cells, um, so that no self-tolerance was ever developed against them. The B and T cells weren't exposed to them. They were embedded within tissue. What else can happen? Lots can happen after you are exposed to microbial infections. Microbial infections can trigger autoimmunity in a number of different ways. Here, some of the examples are here. One is through something called molecular mimicry. That's where a bacteria or a virus possesses antigens that are so similar to a self-antigen that it results in autoimmunity. When the host is exposed to those microbes, they develop a response to the microbe, and then they encounter a host antigen that has similar or even identical makeup, and the immune response that's already been primed to respond to the microbes with the same antigenic determinants react against host. So that's one way. Another way is called a process called epitope spreading, where the immune response to the microbe, it really expands to activate the immune responses to other antigens. So it's kind of a cascading effect almost. Self-antigens sometimes get caught up in that epitope spreading. A third way is through something called superantigens. Sounds pretty awesome, right? Superantigens are antigens that can bind to either MHC2 or T cell receptors, regardless of their antigen specificity, specifically the antigen specificity of the MHC or the T cell receptor. So they're constantly in the process of activating T cells because it's not specific. There's no specific T cell receptor that these superantigens can't bind to through the process of MHC presentation. So it makes them more likely, I guess I would say, to be presented to T cells. And in that case, the T cells then respond to self-antigens that are superantigens. So that's a process that is endogenous to the host and able to trigger autoimmunity. Let's see what else is there. I'm looking here. Stimulation of the immune response. What we're really talking about there is, I guess it's, how about, I know, okay, T cells creating and activating clones of them based on, let's see, let me step back. I can't even say it the right way. Sometimes things like viruses can trigger T cells to create many clones of them. Similarly, you can see this with self-antigens. Sometimes the T cells are activated to produce numerous clones, and as a result, they can trigger other things to happen. So in that case, a T cell, they may have high number of cloning of T helper cells, which will result in some B cell activation, some of the downstream effects of those T cells. And when you clone many of them, you end up with an immune response that's overactive, overstimulated, and it can respond to self. So those are some of the ways, those are kind of the endogenous triggers that we look at. Some of the things that are environmental, those epigenetic factors that I talked to you about, all the things that we hear about and the reasons why you see people, eating organic food and eliminating, not eating from plastics and things. Some of the epigenetic factors that we worry about that are going to trigger those susceptible people into developing autoimmunity, toxins, chemicals in foods and drugs. Also simple things like normal aging. We saw how age affects the immune system before. And also some other modifications that can happen after exposure to some of these epigenetic factors. So it can alter your genetic makeup. And so we worry about those things as well. It not your genetic makeup. I shouldn't say that. It alters the way your genes express themselves. I think that's a better way to put it. All of that can contribute to autoimmunity. All of these factors can activate those self-reactive T cells, can activate those B cells, and result in developing of autoimmune diseases. So it's sort of a, which came first, the chicken or the egg? Look at that. Sorry about that. Antivirus is liking this right now. Genetically susceptible individual is exposed to something, triggers this genetically susceptible person to lose that tolerance and develop an autoimmune disease. Pretty straightforward, and I know I talked an awful lot for something that's so straightforward, but it's important to understand. What do we know about autoimmune diseases? I think I said before, it can be directed as against a specific or a particular organ in the body. We call that organ specific. It can pathologically involve the entire body. We call that systemic. And there's a lot of overlap in both. You'll see diseases that are both, they start out organ specific, it becomes systemic, whatever. Lots of them, over 100 autoimmune diseases. And then we're going to take a look at these in looking at some of the systemic diseases, systemic lupus erythematosus, rheumatoid arthritis, granulomatosis with polyangiitis. They also call that Wegener's granulomatosis. And then some of the organ-specific ones that we've talked about in some measure before with some of these. Some of the thyroid diseases, type 1 diabetes, celiac, some of the liver diseases, MS, myasthenia gravis, and Goodpasture's syndrome. So let's get started. The big one we think of, one of the biggest ones we think of when we talk about autoimmune diseases is systemic lupus erythematosus, SLE for short. Lupus is a chronic inflammatory disease. It affects multiple organ systems, so it's really quite damaging to the patient that has this disease. In this case, patients develop autoantibodies to specifically nuclear components of some of their cells. In SLE, we're going to see that their autoantibodies are directed against the double-strand DNA components called histones, and then again some of the other nuclear components. What happens here is it's an immune complex, so it's a type 3 hypersensitivity reaction like we talked about in chapter 15, 14? I've lost track. 14, I guess. Are we on 14? I'm sorry, I'm blathering. No, hypersensitivity was chapter 14. We talked about it last time. We talked about hypersensitivity reactions and how those immune complexes, the antigen-antibody immune complexes form. They do things like what? They trigger complement, that refers to complement activation, brings in other neutrophils and other inflammatory producing cells, causes things like that redness and swelling, increases inflammation. All that ends up with some cell death and leads to autoantibody development. And the damage comes, we know, when the complexes form out in the tissue and all of this inflammation happens and the tissue gets damaged. So you can imagine if you have a systemic autoantibody that can affect many sites in the body, and it's quite a difficult disease for people that have it. Let's look at a couple of the clinical symptoms of lupus, SLE. As I said, it's systemic, so the clinical symptoms are diverse and they vary in patients. Some of the things we see most often, though, are, joint pain, polyarthralgias or arthritis, so that kind of joint pain. But an awful lot of things cause joint pain, so that in and of itself is certainly not diagnostic. About 80% of the patients see some form of skin manifestation. I wish this was a color picture, but you can kind of see it. This is a typical rash that you see in patients. Again, not a huge number of them. I want to say it's 20 or 30% of the patients have this butterfly rash, but if you see it, it's pretty obvious what it is. And the butterfly rash covers over the nose and cheeks. So that butterfly rash is one of the skin manifestations we see. Also things like vasculitis and petechiae. Some of the other, because this is systemic, we're going to be looking at kidney inflammation or nephritis. And because this is really, really damaging to the kidneys. About half of the patients that have lupus end up in renal failure. It's quite damaging to the kidneys. Some of the other things we're going to see, neuropathies, peripheral neuropathy, so that kind of tingling you feel, so it's a neurologic symptom, and then some other things. We just talked about how this is systemic and it can be affecting a number of different organs and tissues. All of this can lead to a suppression of the hematopoietic system. So you end up with kind of this, it's called pancytopenia. I think you've talked about it. You can end up with different components of it, but if you end up with anemia, leukopenia, and thrombocytopenia, we call that pancytopenia, P-A-N-C, and now I have to spell in my head, P-A-N-C-Y-T-O-P-E-N-I-A, pancytopenia. And it just means a suppression of all your cell lines. What else do we see in patients that have lupus? Now, again, patients may not have all of these symptoms, but these are some of the classic symptoms that we see. Inflammation around the heart, that tachycardia, that's that kind of rapid heartbeat that we see. Pleuritis, kind of fluid. Some anxiety and depression. All of those things can be found in patients that have lupus. How are we going to test for lupus? We start at the beginning. So we're going to look at CBCs, some basic tests, and we're going to see, we may see some of that pancytopenia. Again, that in and of itself, not particularly diagnostic, right? Urinalysis, we're going to see how the kidneys are functioning, because we saw there was some kidney involvement. Again, in and of itself, not diagnostic. We're building a picture of a patient with lupus. So first we're going to look at the blood cells and how those are developing. We're going to look at how the kidneys are functioning. Then we're going to start to look for markers of inflammation, right? That makes sense. We're going to look for things like C-reactive proteins or SED rates. Both of those are kind of, markers of inflammation. And those are going to be increased during what they call flare-ups, those, a period of high immune oh my gosh, can't even talk tonight, during periods of your immune responding to self. So that kind of flaring, I think you guys know what a flare-up, why am I even discussing it? If you don't know, come see me. We're going to be able to measure complement, specifically C3 levels. We can see C3 levels get decreased during inflammation. Why is it decreased and not increased, do you think? Tick tock, tick tock, tick tock, tick tock. Because we've activated it. You're right. So because we're activating complement by those immune complexes, those antigen antibodies, they can activate complement. We're using this C3. So those circulating C3 levels are getting activated into the complement cascade. So they're decreased during periods of inflammation. And then we start to get to the nitty-gritty of this. We can do something called an anti-nuclear antibody test. And I told you just a minute ago that lupus was antibodies against nuclear material, right? So it's anti-nuclear antibodies, or ANAs. We're going to look for that DS, the double-stranded DNA. About 40 to 70% of the patients are going to have this. In and of itself, again, not quite enough to diagnose anyone. We're going to look for antihistone antibodies, and we are going to be looking for antihistone antibodies also found in patients with lupus, frequently in patients that have a drug-induced lupus. So you can be on a drug, be developing the process of lupus, but it's drug-induced, and you take away the drugs and you eliminate the systemic lupus erythematosus processes. So again, dsDNA, lots of patients have it, but you'll see in a few minutes other patients get this too. Antihistone antibodies found in patients with lupus, but when you see those together, the dsDNA plus the antihistone antibody, it's almost always considered positive for drug-induced lupus, and they would treat it as such. So let's move on from there. So, as I said, antinuclear antibodies is really the first test that we're going to do when lupus is really suspected. The patient has other symptoms. Some of those immune tests have been done, and the doctor suspects the patient has lupus. Maybe there's a genetic component to it, all sorts of things. As I said, ANAs are directed against the antigens in cell nuclei. In the test itself, you can see all of these different tests that we can do. We can look for antibodies against anti-dsDNA, anti-single strand, antihistones, and antinucleosomes. We can look for antibodies to centromeres or other nuclear components. We can look for antibodies to extractive nuclear antigens, or ENAs. We can look at anti-SNF, that's anti-SNF, SM is anti-SNF antigen. We can look for, let's see, what else do we have? Anti-RNS proteins. Again, some of the variants of anti-SS, anti-SSB. And so we're going to see a bunch of these different ones. We're going to focus on the ones that are the most commonly seen, and I have a little table for you shortly. This is just to give you a reflection of what kinds of antigens in the cell nucleus we can be looking for. So there's quite a bit. There's quite a large number. Did I tell you? Yeah, I did. Okay. Let's see. Anti-SSA and anti-SSB, those are associated with neonatal lupus. When they're present in the mother, they're found in the mother, and they cross the placenta. So they suspect neonatal lupus when they find them in the mother. It came from the placenta to the mom. What else do we do? We can do other kinds of tests for lupus. We can do an indirect immunofluorescence, and we saw an example of this already. We're going to see this today. Hiccups. There's a test that we're going to see, the fluorescent antinuclear antigen test. It's a fluorescent test. We're going to see that, and this is going to be really, really effective test for the diagnosis of lupus. Some of the other tests, all things that we've seen mostly. We're going to talk about multiplex today? I think we are. Other assays, ELISA, chemiluminescent, multiplex, and Octolani, our friend Octolani technique. Again, we're going to be looking to see for identity and non-identity in Octolani, right? But we're going to focus first on the FANA, the FANA, pardon me, the indirect immunofluorescent ANA principle. It's an ANA test, and it's fluorescent in nature. This is the one that's most widely used test for antinuclear antibodies. Simple test that we're going to be very familiar with. We're going to have a slide, and to this slide they will have affixed some epithelial cells. The epithelial cells that we are looking at specifically are called HEP2, HEP2 cells. And we use these cells because they're big cell with a big nucleus, a big, large nuclei. And within that nuclei, they have a lot of antigens, a lot of antigenic expression. So there's a high degree of antigenicity within the nuclei of those epithelial cells. So we're going to use a really great substrate here to bind to the slide first. So that's first. So they actually come to us that way. We buy them in a test kit. We're not off binding HEP2 cells ourselves. But you can. We know how to do it. You do it with gram stains. You've done it with gram stains already, right? Concept is similar. So HEP2 cells are fixed to a slide. If we had to, we would wash it. Oh no, I'm sorry. We're going to add patient serum to that. Patient serum presumably includes what? The antibody, right? We're going to wash that, and then we're going to add fluorescently labeled. So there's the HEP2 cells. Then we are going to add patient antibody, which God forbid the book would have maybe been red for us, but they didn't. This is the patient antibody. We're going to see if they bind to any of the nuclear components within the HEP2 cells. Of course, we're going to wash, and then we're going to add fluorescently tagged what? Anti-human immunoglobulin. Right. We're going to incubate that. And what are we going to do after that? We're going to wash it. We're going to wash away anything extra. We're going to be looking for the fluorescence. If you don't do a good wash here, it's going to light up like the 4th of July. So we're going to wash, and then we take the slide and we look at it under a fluorescent microscope, and we're going to look for fluorescence. We're going to look specifically in the cells that are in interphase. And we're going to look for a number of different patterns. And so here are the patterns along the side. We're going to look for a homogeneous pattern, one that has diffuse fluorescence all over it. We're going to look for some that just have fluorescence around the rim. So it's an outer rim of pattern of fluorescence. The inside doesn't have fluorescence. The outer rim has fluorescence. That's called a rim pattern or a peripheral pattern. You can have speckled, just like you would expect speckled is, little droplets, little specks of fluorescence around the cell. We can have what's called nucleolar pattern, and that you're going to see is just going to be within the nuclei of the cell. And then centromere pattern, so there's going to be staining just of the centromere within the HEP cells. That's great. We have fluorescence. Well, guess what? In some patients, people have, you have fluorescence normally in patients. Even normal people can have fluorescence. Low level, you can be perfectly healthy and have ANA fluorescence. So by itself, that's not going to help. So, but what they do is they're going to start with a dilution of, say, 1 to 40 of the patient serum. And that way we'll get rid of those kind of low-level fluorescence of normal and just look for the people that are really kind of lighten it up here. Really, when you get to a titer of 160, 1 to 160 and above, then it's clinically significant. So that's when we would call a test pattern abnormal. So let's look at some of the discussion about the test patterns in a little more detail. The homogeneous or diffuse pattern is a uniform staining of the entire nucleus. This is going to be due to antibodies to dsDNA, the histones, or DNP. We're going to see this in SLE, some of the drug-induced lupus, a bunch of other rheumatoid arthritis, or rheumatic autoimmune diseases. So it's not a very specific process, right? We can see that. That's clear. The peripheral or the rim pattern is diffuse staining of the nucleus. So it's just, very, very faint or, but the intensity is around the rim. This is due to antibodies to dsDNA, and this one is very highly specific for lupus. So we're going to see that in the chart in just a minute. Speckled pattern, that fluorescent specks throughout the nuclei. and we're going to see that that is against the anti-ENA or the extractable nuclear antigens. So we're going to see that in a speckled pattern. And some of the patients that we see with this are patients with lupus, scleroderma, and other rheumatic autoimmune diseases. See, we're seeing a pattern that these are not specific in and of themselves. ANAs are a great test, but they're not specific in and of themselves. You have to look at everything kind of together to see what's going on, and then we look at patterns. The nucleolar pattern, as I said, is fluorescence within the nucleoli of the nucleus. It's due to antibodies to RNA and RNP, and seen mostly in patients with scleroderma. And then the centromere pattern, we're going to see about 46, not surprisingly, in each nuclei of the cell. And we're going to look for discrete little speckles within the nuclei. And this is going to be due to antibodies to proteins in the centromeres. And this we're going to see mostly in patients with something called CREST syndrome. And let's take a look just a little further, and we'll talk about this just a little more. Here's you know what? It was very difficult to find a illustration of each of the patterns of fluorescence together, but I thought these were the best ones without getting into some less typical patterns. Some of the more esoteric patterns were in a lot of the illustrations that I saw. But so in the homogeneous, you can see that there's just kind of this all over fluorescence. Speckled, you can see they're speckled, there's little specks, individual specks, and you can grade it. You can, this is different degrees of it. Nucleolar pattern, so this is just in the nucleoli, and there's the centromeres. And I think if we counted these, you'd end up with, if you could have, depending again on the staining, you could find discrete speckles in numbering in the near 46. They should be 46. I don't know if you'd see all 46 if you counted them. And so this is in a little bit different order, so just be super careful here. Homogeneous is first, then peripheral rim, speckled, centromere, and nucleolar. So this is in a different pattern than a different order than we saw it previously. But I liked this little table that said what it was that it was looking for, and then what was the disease we were looking at. So SLE we know is systemic lupus erythematosus. RA that we see here is, we're going to see in a minute, rheumatoid arthritis. SS is something called Sjogren's disease. Let me spell it for you. It's am I missing a letter? I'm trying to write it with my finger. Sjogrens. Sjogren's syndrome. PM and DM that we see here, we're not going to cover today, is polymyositis and dermatomyositis. We're not going to cover those today. PSS is that CREST that we talk about. That's a subset of sclerosis. And this CREST is, so we have sclerosis, and CREST is a version of that where it's, what am I trying to say? It's a cutaneous form. The C in CREST is for cutaneous. Some of the ones that we think of like that are like some of the cold agglutinins we see. Raynaud's syndrome is a CREST syndrome, and it's systemic. And then same thing here, see here. So PSS again is sclerosis. So that's a nice little table. If you wanted to make one yourself, feel free, one that works for you. That's what we're going to talk about with FANA. So what they do is they're going to take all of this information and they're going to look at different patterns, and they're going to be able to aid in the diagnosis of disease and the presumptive diagnosis of disease. And specifically, we will use this a lot for SLE. So what other kinds of tests can we use to detect autoimmune diseases? We're going to look at another test called it's another immunofluorescence test This one is using a substrate of Crithidia lucilii as the substrate. And what this is a organism that has these circular organelles called kinoplasts that have the nucleolus within it, or the kinoplast is within the nucleolus, I should say. And so this is really rich in a specific kind of DNA. It's really specific in, really rich in double-stranded DNA. And so when we're looking for antibodies to dsDNA, this test, Crithidia lucilii, is a great test for us. So it's going to be very similar to what we just saw. You have a slide that is that has Crithidia. I'm getting so tired. Lucilii bound to it. We add patient serum to it. Wash, add a tagged antinuclear antibody or antihuman immunoglobulin. I apologize. I'm going to speak slower. We have a tagged antihuman immunoglobulin that will bind to the patient. Wash it away and see if anything binds. So it's a fluorescence test that we expect to see. Nothing different than what we saw before. Some of the other tests that we do as we start to move into these tests, we're starting to really get out of the world of lupus. We're getting more into some of the other autoimmune diseases. But while we're talking about other tests of the autoimmune system, let's take a look at this quickly. So some of the other tests that we can look at, and actually antiphospholipid antibodies really are not out of the world of lupus yet. I think the next slide should be. Antiphospholipid antibodies, we're looking for antibodies to the phospholipid layer of organs and vasculature. And so we see that in a decent number, about 60% of lupus patients have developed antiphospholipid antibodies. So they develop antibodies. Remember, we're developing, this is a systemic problem. And so one of the things that it does, antibodies are developed against self in the phospholipid layer of organs. We see it in about 60% of lupus patients. We see these antiphospholipid antibodies, but honestly, we also see it in other patients. It's very nonspecific. We see it a lot in patients with deep vein thrombosis and arterial thrombosis. And it is, the test is really interesting. I'll talk about it in just a second. But part of the problems with developing with these antiphospholipid antibodies is they can impact pregnancy and resulting in loss of pregnancy. And it can also interfere with some of our non-treponemal tests for syphilis. So these antiphospholipid antibodies can kind of wreak havoc on the host in a number of different ways. One of the antiphospholipid antibodies that's the most common that I used in the laboratory was called, when we looked for something called a lupus anticoagulant. And so if we knew someone had, when you're pretty experienced, you start to see some unexplained clotting times that are extended, PTs and PTTs, or APTTs, the prothrombin time and the activated prothrombin time, and they become prolonged for really no reason. The patient doesn't have a factor deficiency. There's all sorts of things that kind of go through your head. And one of the things you start to look at is a lupus anticoagulant, that an antiphospholipid antibody. And the reason it extends these tests is that these both use phospholipids in the reagents. So if you have a patient that has an antiphospholipid antibody and one of the test reagents contains phospholipids, it causes a reaction and eliminates this from the reagent test and prolongs the test. So you'll go over lupus anticoagulants soon in hematology, I think. But this is a problematic issue, is going to cause increased clotting in patients and resulting in one of the reasons why these patients have some thrombocytopenia as well, is they're constantly clotting because you're activating this phospholipid that can trigger clotting. So the lupus anticoagulant, if you think of not much more about antiphospholipid antibodies, remember that lupus anticoagulant produces prolonged clotting times, and that while it's not specific, an awful lot of patients with lupus have this. We also, again, see it in patients that have um, um, deep vein thrombosis. So now we're truly moving out of the world of lupus. Let's look at another disease that's a biggie in the autoimmune world. If we're looking at rheumatoid arthritis, and you can see a picture of a patient with rheumatoid arthritis in the lower right hand, or not a whole patient, just a hand. That'd be a bizarre little patient, wouldn't it, if it's just a hand? Getting crazy. Rheumatoid arthritis is another systemic autoimmune disease. It's an arthritis of peripheral joints. It can progress to what you see there, that joint deformity, and really is quite debilitating. The disease itself is one where the immune system attacks the lining of the joints throughout the body. So while we initially may see it in something like the hands and the feet, it eventually can affect many, many joints of the body, and it's quite painful. Patients generally have some characteristic start-off traits, those initial traits when people are first developing rheumatoid arthritis. General malaise, they just kind of feel stinky. They, maybe are tired or, achy. They don't feel great. General malaise. They start to develop joint pain, and it tends to be transient. Worse in the morning, gets a little better as the day wears on. I think I said it starts in the hands and the feet, and is quite often, or generally, I should say, bilateral. It's symmetrically bilateral. So they have it on the left side, they have it on the right side, in just about the same amount of pain. And over time, about between a quarter and a third of the patients develop osteoporosis. We're going to talk about osteoporosis in just a second. Osteoporosis is really just, we're going to see in a minute why, but it's a bone erosion. Let's see, more women than men are likely to get rheumatoid arthritis. Onset is, I've seen patients even earlier than 25 develop rheumatoid arthritis. And again, it's just an autoimmune disease. So it's really, you always think of arthritis being an old person's disease. It's not really. It's can affect people quite young. And some of these patients that develop rheumatoid arthritis can also develop things like subcutaneous nodules, some pericarditis, lung disease in the interstitial areas of the lung, vasculitis. All sorts of additional things can start to develop in patients with rheumatoid arthritis. So what's the pathology of it, and then how are we going to treat it? Rheumatoid arthritis patients develop immune complex formations. Again, it's type 3 hypersensitivity reaction, right? Due to antibodies that are produced, including one called rheumatoid factor and an anti-CCP or anti-cyclic citrulline peptide. Anticyclic citrulline. I can say it. I know I can. I've said it before. Citrulline peptide. Talk too fast sometimes. So those are the kinds of antibodies we're going to be looking at that are characteristic of rheumatoid arthritis. These are the characteristic autoantibodies. The immune complexes, we know, in this case, they're going to deposit in joints, but it's still a type 3 complex mediated hypersensitivity reaction. Beyond this kind of information of antibody complexes forming, depositing in the joint and causing some damage, starts to get a little dicey. A lot is really unknown. It's theorized that this rheumatoid factor, this autoantibody, has something to do with enhancing antigen presentation, so of self-antigen. So they think that it has some enhancing features, and so that's one of the things that they're considering as a trigger of rheumatoid arthritis. Regardless of what we know or we don't know, quite a bit about rheumatoid arthritis, the disease, is quite well known. It's type 3 hypersensitivity reaction, brings T and B cells, brings macrophages to all the spaces between the joints, releasing cytokines, and ultimately leading to inflammation from the release of these inflammatory cytokines. We know about these things, right? Nothing we haven't heard about before. The cytokines can also trigger enzyme releases, proteases that are designed to destroy cartilage. So the cartilage within the joints is destroyed, is damaged and destroyed. And that causes, the bones start to rub together. It's quite painful. What else do we know? Some of the cytokines that are released are interleukins. So they are interleukins that trigger the protease reaction. But in addition to those interleukins that are causing cartilage destruction, tumor necrosis factor A, TNF-A, is released and causes a problem that ends up resulting in bone erosion. So let me tell you how that happens. Normally, in humans, there's a period of it's called bone rebuilding, and so the bones are eroded away and then they're rebuilt, and that's a process that normally goes on and involves osteoclasts. If you think back to, I'm sure you remember because you've done it sooner than I did, about how osteoclasts absorb the bone, resulting in some localized bone erosion. Well, tumor necrosis factor A, when it's released, causes an overstimulation of those osteoclasts. So it's an aggressive absorption of the bone and an aggressive loss of bone. So an aggressive erosion of bone, resulting in, again, quite a painful process, and you end up with these sort of deformed fingers because of this process. The rebuilding can't take place fast enough to match the bone loss. That process ends up systemically being affected. So it's not just the hands and the feet, and that's when you end up with osteoporosis, a loss of bone. So what do we do? Can't just, if we can help it, we try and treat it early and see if we can mitigate this process a little. What kinds of treatments do? They can use NSAIDs, aspirin, ibuprofen, but those are kind of band-aids on that. NSAIDs only really treat sort of the symptoms. They're not going to stop the process. It's going to alleviate some of the inflammatory symptoms that we see. Doesn't really treat the disease. So that's not a treatment of choice. It's just sort of a supportive treatment. There are some quite effective treatments, though, for rheumatoid arthritis, though. Some of them are called disease-modifying anti-rheumatic drugs, or DMARDs. Things like methotrexate, which we see used frequently in different forms of cancer. For example, it's a chemotherapeutic agent, but it can be used also to reduce inflammation, and it prevents disease progression. So that's actually quite effective it works by reducing T cell activation. So methotrexate is something that's effective in reducing T cell activation within patients with rheumatoid arthritis. There are also different kinds of biologic agents that can target, specifically target that tumor necrosis factor A alpha, and stop that effect of causing the osteoclasts to be overstimulated and causing bone loss. So what do we do to block that action of TNF alpha? There are monoclonal antibodies specifically against TNF alpha. They bind off to it. It's no longer going to interact and to cause that process to occur. We can also have some drugs that will cause the receptors on tumor necrosis factor alpha to be fused to an immunoglobulin molecule, specifically an IgG. IgG binds to circulating TNFA and makes it so that it can't cause damage. So two quite effective biologic agents that can limit the impact of the process that we see in rheumatoid arthritis that causes such damage. How do we test for it? This is a good question, the $64,000 question. Clinical manifestations are the first key, really, and then the physicians are going to diagnose by testing. First thing they're going to test for is the presence of rheumatoid factor, and they're going to look for, they're going to use an autoantibody. It's usually an IgM that can react with the Fc portion of IgG, and it will. Rheumatoid factor is usually I apologize. I shouldn't just read. Rheumatoid factor is an autoantibody that can react with the Fc portion of an IgG. As I said, about 80% of the patients with RA have rheumatoid factor, but it's not like all good autoimmune diseases. It's not specific for RA. It can also be seen in patients with no disease, patients with some connective tissue disease like SLE. Oh, there's Sjogren's right there. Scleroderma, some of the mixed connective tissue diseases, and some patients with chronic infection. So it's not individually, it's not a specifically diagnostic test, but when you take everything together in a full picture, it's quite useful. What else can we do? We can do anti-CCP testing. We can look for that, and we're going to use a test that employs antibody directed against the citrullimated protein. So those are very, very specific for RA, and they're done by ELISA testing. So a combination of a positive anti-CPP and a rheumatoid factor is diagnostic for RA, for rheumatoid arthritis. We can obviously also do some ANA testing. Again, not a particularly specific test. Only about 40% of the patients with RA have a speckled pattern developed against RNP. And then some of the other lab testing we see in patients with rheumatoid arthritis is we're going to look at sed rate, C-reactive protein, and complement testing just as monitors of inflammation of patients with RA. So they're going to be monitoring them to see, how effective are the treatments that they're using. Is the patient in a cycle of inflammation or not? These tests, even with treatment, no, I don't think they really ever go away to normal, but they can monitor them to go up or down over a period of time. We're going to move off of RA to granulomatosis with polyangiitis, or Wegener's. And we're going to look quickly at this because honestly, this is a pretty rare autoimmune disease. It involves inflammation of blood vessels in the respiratory tract. It begins with an upper respiratory tract infection and progresses to kind of a more systemic disease involving things like the kidneys and the joints, skin. We're going to see that patients with Wegener's have antibodies to neutrophil cytoplasmic antigens And so that's the form of the antinuclear antibody. And this results in some neutrophil activation, which damages the vasculature in patients with this disease, and results in a T helper 1 response. How are we going to diagnose it? We're going to look specifically for antibodies to these neutrophilic cytoplasmic antigens. So we're going to look for we're going to do a test called an antineutrophil cytoplasmic antibody, or an ANCA. And we're going to look for nodules in, I wonder what I meant to say. There may be nodules in what? I can't even imagine. I'm going to have to think about what that was, because I can't even think. Nodules in the skin? Maybe. All right. What are antinuclear cytoplasmic antibodies? They are, as I said, ANCAs are antibodies produced against the proteins in the granules of neutrophils, strongly associated with a couple of different diseases. And this too is an indirect immunofluorescent assay, in which case the patient's serum gets incubated with on a slide where we have fixed. Let's guess. If we're looking for neutrophilic granules, we're fixing what? We're fixing neutrophils, right? We're going to fix leukocytes to that. We're going to wash it, and then we're going to add a fluorescently labeled anti-human immunoglobulin, right? So we're going to have a slide with leukocytes fixed to it. We're going to add the patient's serum, let it incubate, wash it off, see if antibody bound to the leukocyte proteins, and then we add a fluorescently labeled anti-human antiglobulin to it. Incubate again, wash it, look at it under fluorescent microscope for the presence of fluorescence inside of neutrophils. There's a couple of, do I have it here? I do. There's a couple of different, I should have skipped ahead. There's a couple of different there's a couple of different patterns that we can see in ANCA testing. There is a cytoplasmic, or a C ANCA, and I think, yes, right here. I know this is a busy slide. There's C ANCA, and there's perinuclear ANCA, or P ANCA. Patients that have granulomatosis have or Wegener's disease produce that C ANCA pattern. And so if we look here, these are examples. There's a lymphocyte. So do lymphocytes, those are not going to fluoresce, because remember, we're looking at the neutrophils. We're looking at the nuclear material, or the patterns of fluorescence in neutrophils. So we see a lymphocyte here, and that had no fluorescence at all. So that's good. That's sort of a negative control for us. Those shouldn't fluoresce. If they do, we're in trouble. The cytoplasmic you can see the whole cell is covered, so within the granules of the cytoplasm, these neutrophils are fluorescing. And then you can see, do you see you see the full circle, right? So you see the full circle of the cell here. This, though, this is showing the perinuclear, so it's around the nucleus. So the thing, look at this and imagine, see, you're not seeing the rest of the cell, which would be round. See how irregular it is? It's because the fluorescent is around the nucleus. So it's neutrophils showing perinuclear staining. And that's how you tell the difference. So this is a positive C ANCA test, and this is a positive P ANCA test. In C ANCA, this is caused by antibodies to what's called proteinase 3, or PR3. And it causes staining in between the nuclear lobes. So that's the C ANCA, right? In the P ANCA pattern, the fluorescence surrounds the nuclear lobes, kind of blends them together. And these, we're going to look for something that's called myeloperoxidase. I don't know if you've done myeloperoxidase testing yet in hematology. You will. You'll talk about myeloperoxidase as an indicator of disease later, I'm sure. Um, so when we're looking at this, and I should mention this about ANAs as well, you have to be good at reading this. This isn't something that you throw on a fluorescent microscope, and all of a sudden you can read these effectively. This is actually quite a skill that you need some very specific training to do. And you'll see it. Hopefully you'll see it when you're on clinical, though it's not every place does it. But if you do, you'll see that people are trained to do it. And you can certainly learn how to do it, but it's not something that you just start, doing it and diagnosing people. P anchor is similar in patterns to the peripheral ANA pattern. But they're different cell types here, right? So this one we used neutrophils, and with ANA we used what? We used those epithelial cells, right? The human epithelial cells, the HEP2. So they're different. And we can always back these things up with doing things like ELISA testing to test for the PR3 of this. So, FANA, anti-neutrophil and cytoplasmic antibodies are useful, but in a lot of ways, some of these tests are being replaced by things like ELISA testing. So it's important to know. I'm almost positive you'll see something about this, about these things, about ANA testing, about ANCA testing on a board exam. I can't imagine you wouldn't be. We talked a little bit about this last week, I think. In this case, we're going to talk about some thyroid diseases, autoimmune thyroid diseases, or AITDS. We talked, I think, last week really about when we were talking about inhibition reactions, the inhibition reaction within the thymus. But the production of thyroid hormones are really carefully regulated. Not too much, not too little. Last week we saw too much, right? And that we saw that normally there's this inhibitory reaction that when, in this case, if there's too much T3, T4 that's produced, it inhibits the production of TSH, the hormone. And so there's this process where there's an inhibition reaction. And so normally that feedback loop is going to be monitored and regulated in a process they call the thyroid axis. This process right here, the thyroid axis. The hypothalamus secretes something called thyrotropin releasing hormones, or TRH. You can see that right here. Releases TRH, and that stimulates the pituitary gland to release thyroid stimulating hormone, or TSH. I think we've all heard of that. TSH then stimulates the thyroid gland to produce T3 and T4, and there's an enzyme called TPO, or thyroid peroxidase, that kind of oxidizes the ions that get incorporated into the thioglobulin. So this process is, there's the TPO right there. This process can inhibit this reaction of thioglobulin to T3 and T4. This reaction can be inhibited, this reaction can be inhibited, and it's all based on the production of T3 and T4. And so there's this feedback loop. If we don't have enough of this, then this gets, it's not inhibited. So there's either a stimulation or an inhibition of the production of antibodies that can bind this binding site, where after pituitary gland releases TSH, it has to bind into the thyroid, into a receptor on the thyroid, in order for the rest of this reaction to take place. And so what we're going to see in autoimmune thyroid diseases, that there are diseases that can interfere with some of these processes. And so in Graves' disease, for example, we're going to look at a couple of them specifically. We're going to look at something called Graves' disease and Hashimoto's disease. And in Graves' disease, there are autoantibodies to the TSH receptor. So there's an antibody to the TSH receptor that blocks the binding site. So this feedback loop doesn't happen. You're binding off to both the inhibitory and to the stimulatory binding site, and it can end up increasing the thyroid hormone synthesis. So antibodies block the receptor site. So the feedback loop is really ineffective, and we're going to see the effects of that in just a second. In Hashimoto's disease, though, there are antibodies to thyroglobulin and TPO, which can lead to a decrease in the result of these hormones, these hormones that need to be synthesized. So the process of Hashimoto's disease is producing autoantibodies that interfere within the thyroid to release T3 and T4. So in both of these cases, there's antibodies that affect the processes of the thyroid axis, and they result in disease. Hopefully this makes sense. This also should mention in Hashimoto's that can result in the development of or the activation of cytotoxic T cells that can release cytokines that can also damage this really square, not so square thyroid. Shouldn't be square, clearly. So those are the three actions that we worry about in Graves' and Hashimoto's disease. And those are going to be the effects that we're going to see in just a minute. I know it's complicated. Go back and read it just a couple of times. I think it will make sense. Take a look at the illustration. All right. Hashimoto's disease is the most common autoimmune disease. It's seen mostly in middle-aged women. And you recognize it. I should have done a picture. It's a goiter. It's an enlarged thyroid gland. So in this disease, the thyroid gland becomes irregular and kind of rubbery. And the process involves destruction of the thyroid gland that we just saw in Hashimoto's, and produces, because we are impacting this process within the thyroid, we end up with hypothyroid. We're not going to produce more. We're not going to produce a sufficient amount of production of thyroid hormones. Let's see. How does it process? What's the process for this? We saw there were autoantibodies that can interfere, but those autoantibodies can also activate complement and cause damage to the thyroid as well directly. What happens in this? We see symptoms of fatigue, dry skin, weight gain, very brittle hair, and that classic formation of a goiter. Lab results that we see, a normal or high TSH. We're going to look at this picture again in just a second. So let's remember this. Normal or high TSH, low free T4, anti-TPO, and anti-TG, thyroglobulin. So these are the antibodies, right? So either anti-TPO or anti-TG. So if we look here, there's the antibody to TG, and here's the antibody to TPO. There's the hormone TPO. So this binds off to TPO and interferes with this. This binds off to the thyroglobulin and interferes with this process. And so you end up with excess free T4 because we're not processing this to bind it off to T3. And T4 ends up being too high. So there ends up being free T4. It's unbound to protein. What else happens in this? So you can end up with normal or high levels of TSH. So this is still being produced. The pituitary gland is not being inhibited here, and so you end up with too much TSH here. And it's those are kind of the classic symptoms of Hashimoto's thyroiditis. Graves' disease, quickly, is another autoimmune disease of the thyroid, characterized by, in this case, by hyperthyroidism. Again, most often women, usually women in their 50s and 60s. In this case, the goiter that might develop is not kind of rubbery, but it's quite firm. It has a different feel to it, although it's still that growth at the thyroid. Patients that have Graves' disease are characterized by the eye. It's called exophthalmosis. Exophthalmos. Add an extra S. I don't know if you've seen any of those Mel Brooks movies, but oh my God, his name just went out of my head. You guys will know. He was in Young Frankenstein. Marty Feldman. He had those really bulgy eyes. That's what Graves' disease is. And so it's as a result of there is the eye muscles. There's hypertrophy of the eye muscles that causes the eyeballs to bulge out. Let's see, Graves' disease is characterized by antibodies to thyroid stimulating hormone receptors. And so the antibodies to the thyroid stimulating hormone receptors here, remember there's the thyroid stimulating hormone receptors, the antibodies bind to the TSH receptors, and it tricks the thyroid into thinking that TSH has been bound in there. In this case, it binds in. It looks like it's bound in. This, I'm sorry, should be an inhibitory one. It looks like it's bound in, and it tricks the thyroid into excessively releasing T3 and T4. So it's a hyperthyroid. This feedback loop doesn't happen because it thinks that the pituitary gland is producing TSH when it's not. It mimics it. So we'll look and we'll see a low TSH here. This will be low, but it's going to have, because we didn't actually produce TSH, but it'll have a lot of free T4 because we tricked the thyroid into producing it. So let's move on to the last few. Diabetes mellitus. I think a lot of us know and understand what this is. This is an endocrine disorder characterized by hyperglycemia, or a high level of glucose in the blood. Type 1 can be contrasted with type 2 diabetes, where in type 2 patients develop a resistance to insulin. We hear all the time about this insulin resistance. It's usually due to obesity or other factors. Type 1 used to be known as juvenile onset diabetes because we usually see it in children, but the reality is that type 1 is, honestly, it's caused by an immune response in which the beta cells of the pancreas are destroyed, and this results in an insulin deficiency, and we end up with high levels of glucose in the blood. As a reminder, insulin works by absorbing glucose, promoting the absorbance of glucose by the muscles or fat, so it can be converted to energy. So if you're lacking insulin, the cells are not being absorbed by muscles and into the fat, and it's remaining in the blood, and that's how you end up with a high glucose level. The destruction of these beta cells in the pancreas occurs by T helper 1 response and the release of cytokines that are inflammatory in nature, and they ultimately end up destroying the beta cells. So you don't see it. There's a period of time. It takes a period of time for those beta cells in the pancreas to be destroyed. Let's see. How do we treat people with this? we have to give them insulin. We have to, people have to inject themselves with insulin to control the blood level. There's all sorts of experimental treatments that include things like immunosuppressive drugs, some of the biologic agents, maybe monoclonal antibodies, maybe transplants of beta islet cells or stem cells. So there's things that are being looked at, but they're not there yet. Some of the long-term effects of this, a lot of damage to the cells of the body. Cardiovascular disease, kidney dysfunction, nerve damage, blindness, infections, all quite, it's quite a debilitating and, ultimately deadly disease. Some of the lab results we're going to look for testing for blood glucose level. We'll look and see how it is as a proxy for understanding how the patient's insulin levels are. We're going to look for something called the A1C, the hemoglobin A1C. It's a glycosylated form of hemoglobin that's made when the protein combines with sugar, with glucose. So the hemoglobin A1C is a very good correlation of the average plasma glucose over a period of time, usually a couple of months, 2 or 3 months. It's not affected by what you eat in the morning on the day of the test, and it really looks at how well your body has been processing glucose over a period of time. And we can also look for some of the autoantibodies in this. We can look for something called antibodies to GAD, or glutamic acid decarboxylase 65. That's a mouthful and a half. Or IA2, insuloma antigen 2. Antibodies can be, I should say also ICAs, islet cell antibodies. We can look for these specific antibodies to see if that's what the patient, if these autoantibodies are causing the patient to have type 1 diabetes. So we can look for specific autoantibodies, including these 3 that I mentioned here. Celiac disease we'll discuss quickly. I think everyone at this point understands and knows what celiac is. Celiac is a disease that affects the intestine and other organs, and it's one that's triggered by gluten, which is a protein in wheat. Barley and rye. Riley and bar is what I was going to say. Gluten is a protein found in wheat, barley, and rye. It's in this case, autoantibodies are formed in patients to specific things. Their autoantibodies are formed to gliadin, which is a component of gluten, and undigested gliadin can trigger an autoimmune response in patients. It can also be against tissue transglutaminase, or TGA, and TGA is an enzyme that converts glutamine into gliadin and glutamic acid. So it's we can develop, that's again another part of the processing of gluten that autoantibodies can be formed towards. And let's see, and endomycin or EMA can also be trigger an inflammatory response in patients with celiac. Oh my gosh. Endomycin antibodies are antibodies that are directed against kind of the connective tissues around intestinal muscles, and it's very, very specific for celiac. So if patient has a test for endomycin antibodies, it's easily diagnosed for celiac. So those are really the 3 autoantibodies that we're going to look for to see if a patient can be suspected to have celiac disease. A lot of people say they have celiac, but they don't really have autoantibodies. They may have a little bit of sensitivity to it, or maybe they feel better with it because maybe they don't have some inflammation. It doesn't mean they have true celiac. the first tests that we did were really serologic testing for gliadin antibodies, but they don't use that so much today. It's not a really super specific test. Um, so instead, we're looking for things like the tests against EMA, that are quite specific. Um, they can also do an invasive test like a biopsy of the small intestine, to confirm diagnosis, so they can actually see if there's damage, to the organs there, based on gluten allergies. Um, or I shouldn't say allergies, gluten, antibodies to gluten and its components. Some of the symptoms, it's not life-threatening, diarrhea, abdominal pain, bloating, but you can have some damage. And treatment, follow a gluten-free diet. But like I said, they, will, I'm sure, develop some treatments that can help people to live. Not that you can't live a life without gluten, that's for sure. I know people that have it. I know a young girl that was in my Girl Scout troop had it, and she is fine with it. But there was a little failure to thrive in the beginning when she was young. She was diagnosed with it probably 6 months old, 8 months old, and she had a little failure to thrive for a period of time while they were looking that over. Maybe it must have been later than that. She was a toddler. I apologize. She was a toddler. But she was very, very small and not growing, and they suspected celiac. Autoimmune liver diseases, these are terrible. They can end up leading to end-stage liver disease if they're left untreated. We used to think of these things like chronic active hepatitis, autoimmune version, it's a version of autoimmune hepatitis, where we have autoimmune autoantibodies targeting hepatocytes, targeting the liver cells. So autoimmune liver diseases, let's see, clinically, you end up with crazy liver enzymes. Your livers just don't function well. They're so damaged. Kind of that general malaise, fevers, nausea, some vomiting, abdominal pain, itchy skin, and jaundice. When your liver's not working well, you end up jaundice. As I said, it's an autoimmune disease. They used to call it chronic active hepatitis. And there's a couple of different types. There's autoimmune hepatitis 1 for smooth muscle antibodies. And we see that those SMAs, we see those in ANA testing. And AIH2, pardon me, are positive for liver and kidney microsomal antigens. So we're going to see antibodies to LKM1 antigens. What happens in these patients? They end up with really biliary cirrhosis, damage to the bile ducts, cholestasis. So they end up with gallstones, and ultimately the patients do end up producing antibodies, mitochondrial antibodies, that get detected on another immunofluorescence test that looks at using a substrate on the slide instead of hep B cells or leukocytes. They're going to use some tissues that have that are mitochondrial rich, and they use things like liver of rats, rat liver or mice liver, kidneys, stomach sections, things like that. So they take cells from rodents that have a lot of mitochondria, and they look to see if the patient has an antibody to that, and it's very specific. So those are the autoimmune liver diseases. We're going to do more about hepatitis later this semester, as a general rule. Let's look at, I think, almost our last one, just a couple more. Multiple sclerosis. So bear with me. I know this is running long. I can't stop. Multiple sclerosis is autoimmune disorders. I think most people have heard or know about MS. This is a disorder that involves damage to the central nervous system, in which case patients develop an antibody to what's called the myelin basic proteins. That's the sheath that covers the covers the nerves in the central nervous system. So when you wear away that myelin sheath, you end up with really, disturbances in function of the nervous system. We're going to see that plaques form in the white matter of the brain. You'll see plaque when they do an MRI of the brain. They can see plaque formation in the brain and the spinal cord, and that's what destroys that myelin sheath. So you'll have these antibodies against myelin basic protein, and then you have this plaque formation, this complex formation in the white matter of the brain. Some of the things that happen: visual disturbances, weakness in limbs, dizziness, some sensory abnormalities. It's quite a devastating disease if you've ever known someone that had it. Laboratory findings, we're going to see those lesions, those plaque formations on MRI. And we can see very, very specific immunoglobulins in spinal fluid. You're going to do this in chemistry in much greater detail, but you're going to see what's called oligoclonal bands on protein electrophoresis of CSF, and we're really looking for increased IgGs. And you'll see there's going to be a specific ratio of looking at those oligoclonals, or means a couple of different bands, 2 different bands, 2 or more oligo. So it could be 2 or more distinct bands of proteins. So we're going to be able to look at those bands of proteins on electrophoresis, and there's going to be a ratio of IgG to albumin, and we compare it to the same 2 components, IgG antibody and albumin in the serum. So we compare the serum results to the CSF, and we can assess a patient for MS that way. That's quite a horrible autoimmune disease. Another one, myasthenia gravis. This is an interesting disease as well. This is one of those other ones where antibodies bind to a receptor. And I think we talked about this last week. In this case, autoantibodies are developed that bind to the acetylcholine receptor and result in some physical manifestations we'll talk about. So myasthenia gravis is, a neuromuscular disease, results in weak skeletal muscles. We see this with patients with really drooping eyelids. I didn't take a picture. I can't believe it. If you see a picture, I did last week. If you look back last week, you'll see sometimes it's just one eye, really droopy eyelids. Patients end up with, symptoms like double vision, or unable to retract the corners of their mouth. They have trouble speaking as a result. They have trouble swallowing. It's, again, a really devastating disease because the antibody that's produced, the autoantibody, blocks the acetylcholine receptors here. The normal acetylcholine binds in here, and it causes the synapse to the junction to be made. But if we bind this here, acetylcholine can't bind into it the way it needs to, and the muscles don't respond the way they're supposed to. They don't contract because there's this acetylcholine, which causes that reaction to take place, can't bind in. So it blocks the binding site of acetylcholine receptors. And most of the patients with myasthenia gravis, that's the cause, antibodies to ACH receptors. And the result is that the nerves just can't activate the muscles. Some patients do develop some other antibodies. Some develop antibodies to some, specific lipoproteins in the muscle, or a muscle-specific kinase, for example. But most often we see it in the ACH receptor. And finally, thank you for your patience, Goodpasture syndrome. Patients that have Goodpasture syndrome produce antibodies to the basement membranes of the kidneys, the renal glomeruli, as well as the lungs, within the lungs, the lung alveoli. These autoantibodies obviously bind to their specific antigen, their specific self-antigen. Immune complexes form, attract complement, and you end up with damage, and it says type 2, but it should be type 3 hypersensitivity. So we're going to have a complex mediated hypersensitivity here. The syndrome itself can progress to, it's quite damaging. It can progress to renal failure, some respiratory problems, things, the manifestations don't sound bad: cough, shortness of breath, blah, blah, blah. But they're actually quite damaging because they're far-reaching, and they're kind of not stopping. So antibodies to the renal glomeruli are found in almost all the patients, and we detect that by the glomerular basement membrane, the renal glomerular basement membrane. It's detected by another immunofluorescence test, in which case the substrate is frozen kidney sections, or they can actually do ELISA testing for antibodies to the specific alpha-3 chain of the lungs that's the subject of one of the autoantibodies. So they can do some ELISA testing, they can do immunofluorescence, and then it can also do some things like kidney biopsies and do an immunofluorescence on that. So it's actually fairly easily detected with the right methodology. Anything else? Oh, I just want to be very, very clear. As I was looking at the slide, I saw the typo there, and I said it, but make sure that you correct it on your paper that that's type 3, not type 2. And so we're going to close. And so I did not do any questions during the middle of this lecture, and I realized it. So I'm going to ask you one question at the end, and hopefully you know. So in Goodpasture syndrome, on the slide on Goodpasture syndrome, I made a mistake in what type of hypersensitivity reaction this was. We know this is an immune complex hypersensitivity reaction. So for your participation question, please let me know what the correct type of hypersensitivity reaction is seen in Goodpasture syndrome. What is the correct type of hypersensitivity reaction? Let me know what that is, and you will get your points for participation. Thank you again for your patience as I went a little bit over today, and I will try and talk less next time. It's an awful lot of material we cover here, people. I talk as fast as I can. Thank you so much, and I'll talk to you soon. Take care. Bye-bye.